Management of heart failure with preserved ejection fraction, often called HFpEF, is often called the greatest unmet need in cardiovascular medicine. For decades, heart failure was defined by a weak dilated pump, that is, heart failure with reduced ejection fraction, HFrEF. In HFpEF, however, the heart pumps out a normal percentage of blood, yet the patient is breathless, exhausted, and at high risk of death. Here is a breakdown of why this paradox makes heart failure with preserved ejection fraction so notoriously difficult to manage. In heart failure with reduced ejection fraction, the heart is like a stretched out balloon that can't squeeze. In heart failure with preserved ejection fraction, the heart is like a stiff rubber ball. The left ventricle becomes thick, stiff, or scarred with fibrosis. While it can squeeze well enough to empty, there is normal ejection fraction, it cannot relax or fill properly. Because the ventricle is stiff, it takes much higher pressure to force blood into it. This back pressure travels into the lungs, causing pulmonary edema and shortness of breath, even though the pump looks fine on a standard echo. Unlike heart failure with reduced ejection fraction, which has a clear hallmark, an ejection fraction below 40%, heart failure with preserved ejection fraction is a diagnosis by exclusion. Patients are often older and have a perfect storm of other issues: obesity, hypertension, type 2 diabetes mellitus, and chronic kidney disease. Shortness of breath in an 80-year-old patient with obesity and COPD is often attributed to age or lungs, meaning heart failure with preserved ejection fraction is frequently caught late. A normal ejection fraction, typically more than or equal to 50%, can give clinicians a false sense of security, leading to dangerous assumption that the heart is healthy. For decades, the triple therapy, ACE inhibitors, beta blockers, and MRAs saved millions of lives in heart failure with reduced ejection fraction. When these same drugs were tested for heart failure with preserved ejection fraction, the results were frustratingly neutral. Beta blockers are life-saving in heart failure with reduced ejection fraction, but often poorly tolerated in heart failure with preserved ejection fraction and can worsen chronotropic incompetence as well. ACE inhibitors or ARBs, which are the gold standard in heart failure with reduced ejection fraction, has minimal impact on mortality in heart failure with preserved ejection fraction. ARNI, that is sacubitril valsartan, was a revolutionary combination in heart failure with reduced ejection fraction, but the benefit was borderline or limited to specific subgroups in heart failure with preserved ejection fraction. The reason for this failure is that heart failure with preserved ejection fraction isn't just a heart problem. It is a systemic inflammatory state affecting the blood vessels, kidneys, and skeletal muscle. The paradox began to shift with the arrival of SGLT2 inhibitors like empagliflozin and dapagliflozin. These diabetes drugs became the first therapy to show a significant reduction in the combined risk of cardiovascular death or hospitalization for heart failure with preserved ejection fraction. They work not just by diuresis, but by improving metabolic efficiency and reducing the systemic inflammation that drives the stiffening of the heart muscle. Here is a summary of management challenges in heart failure with preserved ejection fraction. Heterogeneity. No two heart failure with preserved ejection fraction patients are the same. One might be driven by obesity, another by long-standing hypertension, and still another by amyloidosis. Exercise intolerance. Heart failure with preserved ejection fraction patients have a stiff cardiovascular reserve. When they try to walk, their heart pressure spikes instantly. Volume sensitivity. They have a narrow sweet spot. Too much fluid and they end up in the emergency room. Too much diuretic and their kidneys fail because the stiff heart requires some pressure to fill.